the initial therapy for patients with CLL has emerged quite dramatically. I think patients have many more options available today than they ever did before. Ibrutinib is now standard therapy, although we can discuss there are maybe patient characteristics that there are folks who may not want to be on ibrutinib depending upon their comorbidities, and I think that's something that patients need to discuss with their doctors. Chemoimmunotherapy, you know, in the era of traditional therapies we used to use for CLL, so fludarabine, cyclophosphamide and rituximab, or FCR, and bendamustine and rituximab, or BR, were the prior therapies that many individuals and many of you may have received. I think there's been very good advances going forward that ibrutinib has enhanced has improved both survival of patients with ibrutinib versus perhaps the older therapies. However, I think there are still a select group of individuals or patients who may prefer to receive chemoimmunotherapy, which is not unreasonable. However, I think that if somebody has high-risk features to their disease, so if there are adverse chromosomal abnormalities like a 17p or a p53, we would steer those individuals away from chemoimmunotherapy in favor of ibrutinib. Patients who have a unmutated IGVH, and again, these are sophisticated tests your doctors should run before getting therapy. Again, we would steer those individuals away from chemoimmunotherapy. I think if you have favorable characteristics and you do not want to go on a drug like ibrutinib for a variety of reasons, then chemoimmunotherapy is still okay. But I think there's very good data for all individuals with CLL, whether you're older or you're younger, and even with comorbidities, that ibrutinib is very manageable and acceptable. So I do think that you have options, but more favoring these newer agents such as ibrutinib than before.